to the Committee on Health, Human Services, Finance, and Policy for today, July 29th, 2020. Um, Members, we don't have official language before us. We're not in session, so we don't need a quorum, but a lot has happened since we had our last meeting. And now that we're evidently between special sessions, I wanted to follow up on some of the work that MDH has been doing. There was a lot of commitments made and a lot of funding has been put forth. And so we're going to start with talking about where testing has been, what's going on with the LAC requests, some data questions, and Commissioner Malcolm has a good team here. It's not our entire team because they've been solving all of the problems, it seems, as it relates to COVID. And so we're glad that you were able to take time to be with us here today. Our goal today is to have transparency on the spending that's being done, accountability for commitments that have been made on testing in this critical time. COVID is impacting our economy. We'll find out tomorrow how it's impacting education this fall. Every single family is feeling it. MDH is at the heart of it. And so we as a committee have a responsibility to understand and to be accountable for how Minnesotans are functioning during COVID. And with that, we sent a list of questions to Commissioner Malcolm. She and her team are going to do their best to answer them. We have a very generous hour. Thank you, Commissioner. So let's get started. Welcome, Commissioner Malcolm.
Madam Chair, thank you. And members, good afternoon. I apologize that I'm not fully virtual with you, but really appreciate this time. I know you do have a number of questions and we have a number of people lined up to answer them. I just wanted to open up with a couple of comments. I think, and I'm not sure if Bailey or who is going to we just have a couple of slides, or at least I do. Just wanted to share with you the most current epidemiologic curve. So you can, and I think it does a nice job of just visually, you can really see the path of the pandemic in Minnesota and how we kind of grew pretty gradually for a period of time. And then second half of April and the first 2/3 of May, we saw really significant rates of growth. Then we were all happy to see that those growth rates coming down pretty dramatically through really the end of May and the first 3 weeks or so of June. And then we see the growth rates starting to pick back up. One thing just to make clear about the data, we use for all of our really analytic purposes, we take all of those laboratory confirmed cases that come in, and they do come in literally on a round the clock 24/7 basis through an electronic laboratory reporting system. But for analytic purposes, the cases get assigned to an onset date, which we count the date that the lab specimen was collected as the onset date. That helps us kind of eliminate the noise that comes around the very different turnaround times that laboratories have for getting results back to us and to the provider who ordered the test, who then communicates with the patient. So onset date is critical. We also know, because of the time that it takes for those lab results to come in and fully get attributed correctly, we use a 7-day lag period in most of our calculations. So you see that on the epi chart, that at the end of the chart there to the far right, there is a lag period. Now, what we already know, and based on what lab confirmation numbers we get each day and that we report publicly each day, that those numbers during the lag period are gonna continue to go up. So you don't see it on the chart yet, but we kind of know what's in the pipeline in terms of looking at some continued rates of growth. What we don't know entirely is we've seen this kind of bouncing around pattern many a time on a day-to-day basis, several days of up, several days of down, several days of up. But if you just kind of look at the overall trend, you can see whether averaging all that out, we're going in in generally one direction or another. So I think that EpiCurve is just a really valuable visual tool to understand, kind of what's happened in the past, and that certainly helps inform kind of our understanding of how quickly things can move, and that we hope through the efforts of everyone in the state, the mitigation measures that we keep harping on at MDH about social distancing and mask wearing and avoiding close contact for long periods of time, that all together, all of us can play a part in keeping those rates of growth in the kind of manageable zone, rather than beginning to just compound on each other, like we saw earlier or later in the spring. Madam Chair, I know that some of the questions that you have are about the University of Minnesota model, when that is going to be rerun. And I'll give you a little update on that. The university is telling us that we are expecting a rerun of the model within the next several weeks. I know it's not going to be any sooner than I would say, not any sooner than the middle of August was what I'm understanding. And what they're doing is really trying to update the model with more Minnesota data, better fitting some of the assumptions to not kind of what they were modeling off of, kind of some of the earliest predictions of the transmissibility and the rates of hospitalization, but fitting that more closely to what we've actually seen in Minnesota. So that next run of the model will have a lot more Minnesota data in it. And as we have said many a time, it kind of shows a wide range of potential growth rates and potential hospitalizations, and even mortality. But we think that, perhaps with more Minnesota data in it, the fairly wide range of assumptions might start to get a little bit more refined. Certainly some of the big variables that have changed since the first model was run are the role of asymptomatic transmission, and the especially recently, the somewhat more favorable experience we've had with fewer patients needing ICU level care, as care itself has been improved, earlier interventions with oxygen therapy helping to avoid some ICU use and the like. So I think the next run should be instructive in that way. I do want to say, yes, Madam Chair.
Commissioner, we still have some slides on our screen. Are you finished with the slide deck? We didn't go through all of them, and I know your technology compromised right now, so I just wanted to, if we can unshare those
Sure.
slides.
Thanks, Madam Chair. Thank you. I appreciate you telling me where we are. I wanted to mention the model before talking about the dial back indicators, because I know one of the questions has been, well, if you don't have an updated model, what are you using to inform these various policy decisions and health guidances? So that's where I wanted to kind of pivot to the dial back indicators that we've been posting publicly for a couple of months now. And I won't spend a lot of time on them, but if you have questions, we can certainly answer them. But that there you see on those slides just sort of how we've been trending against those dial back measures. And the one more thing I would say, you see on each slide there's a threshold, but there actually, for our internal planning purposes, we actually have kind of more than one threshold. We have kind of a lower level indicator of concern, which is maybe and then a higher level indicator of concern. So for test positivity, for example, you see a threshold of 15%, that if a community or a state is over 15% test positivity, that's a sign of a pretty rampant rate of growth and spread. We actually track and get a little concerned when we get over 5% test positivity. Some of the states and regions that are in, kind of in the best control, so to speak, are down around the 2 to 3% test positivity range. So I just wanted to let you know that even though you see specific thresholds on these charts, those are kind of our, upper limit, if you will, of concern, but that we actually are tracking some lower thresholds for planning purposes as well. So, Madam Chair,
Commissioner,
I'll leave it there
if
unless
I,
you have questions. Yep.
yeah, if I could, so as I look at that, so we're starting to see some constraints on testing, and we're shifting from a general population testing back to a more symptomatic testing. So in that case, wouldn't we expect to see an increase in the percent positive? And
Yep.
we are constrained by reality. So I just want to call this out now, that if we're having restricted testing, we're probably going to see increases in positivity. And I just want you to comment on that.
Thanks, Madam Chair. It's an excellent point, and it really goes to show why we don't use any one of these indicators as the thing all by itself. Because as you point out, there's context around everything. So to understand where are we testing and has that changed, and what might that do to positivity rates. So we really try to look at a compilation and really a blending, a synthesis of all of these different indicators to kind of help us kind of come at these questions from a variety of different angles. And in addition to these so-called dial-back measures that we've been posting publicly, there are a bunch of additional epidemiologic surveillance indicators that we also look at. Things like frequency of visits to urgent care and doctor's offices, and for what kinds of illnesses. And some of those things are more a leading indicator than some of what you see here. A number of these things are kind of lagging indicators for where the disease actually is. So great question. And again, just underscores the point that all of these things need some interpretation, some context, and to really be looked at as a whole, rather than saying, well, that's the one measure that's going to, really dictate the decisions. It's more nuanced than that. So thank you. And with that, Madam Chair, I think we turn it back to the specific list of questions that you had.
That would be great. And Commissioner, did your staff review the questions, and do you just want to move through staff by staff, or would you like me to start moving through questions?
Yeah, I think we've got the list that you sent over, and I think I'll just ask our legislative leader, Lisa Timian. Lisa, do you have a specific way that you would like to prioritize this, or we'll just have the senator ask the question and the assigned staff person can answer? What I would imagine.
I think we can go with what the senators, what order they'd like to, and I think we're ready to respond. So
great, thank you. Go ahead.
So the University of Minnesota and Mayo Clinic had a collaborative agreement with MDH. So what is the status of that contract, and what deliverables are we looking at? So I'm not sure who's going to take all of these. I know Commissioner Kelly gets a lot of testing questions. Welcome, Commissioner Kelly.
Thank you. And Commissioner, while you're on the phone, if there's anything you want to say and jump in, feel free to. But I will start with the Mayo U of M contract. So our goal with the contract with Mayo and the U of M was to build capacity for testing so that everyone in the state who needs to get tested could get tested. And we're also trying to build capacity for hotspot, what we call hotspot testing, where there are outbreaks. So this contract was instrumental, has been instrumental in helping us to achieve our goal of 20,000 tests per day, which we did accomplish on either June 9th or June 29th. I don't recall which day, Commissioner, maybe you do.
That was the 9th, I believe.
The 9th. And so we're using the Mayo and the U of M lab capacity for testing in long-term care facilities, for our mobile testing events, and for other hotspot testing. And so via the contract, they have given us a reduced price of $62 per test. And so when we go out to long-term care and do swabbing, those tests are sent either to the U of M or to Mayo for processing. When we do community-wide events, those tests are sent to the U of M and Mayo for processing. We have exhausted the testing portion of the funding in that contract, and we're currently amending it to move funding from other lines of the budget to the testing line in the budget, from equipment, from personnel, from databases, to reflect what we are projecting are going to be our needs in the coming weeks. We'll likely need additional funding for testing to cover the events. And we're working with Mayo and the U on reimbursement, and we're starting to see funds being returned or ready to be returned to the state from insurance reimbursements. So hopefully we will be able, those funds will go back to the COVID-19 fund, and we can seek reallocation of those funds to continue to cover testing costs. And I would add that a benefit of the contract is that any capacity that Mayo or the U of M has on a given day that has been made available to the state that we have not been able to use gets made available to other healthcare providers around the state at the negotiated contract rate of $62, which is considerably lower than the national reference labs that many of our state health care systems use. Health providers are still saying that they want and need even more capacity, and we would agree with that capacity for lab testing.
And Commissioner, were they also doing serological testing? Were they the contractor for serological testing?
So serologic testing was an aspect of the contract, and we have done very little of that. We are not, and Chris Erzman, feel free to weigh in on this, but we have not found a reliable serology test yet that we want them to use, but we have used that testing, serology testing, in funding we received for serology tests, seroprevalence studies. So,
Senator Benson.
Yes, Senator Jensen.
Thank you, and thank you. All the folks from Department of Health and HHS. To follow up on your question regarding testing, and you used the word reliability, and you talked about serology. Can you just give us a little bit of an understanding of where you put the quality of the testing we're utilizing regarding the PCR tests in terms of what other states might be using? Is there a difference between the tests that might go on through Mayo Clinic or through the University of Minnesota, through the Department of Health? And specifically, could you comment on maybe sensitivity and specificity? Because we're hearing all over the nation concerns about a test that's positive on a Thursday is repeated on a Friday and is negative, and another test on a Friday is negative. And I think that we have a little bit of an issue with confidence in testing. So I guess I'd like to focus not so much on the serology, but on the PCR molecular testing in regards to sensitivity, specificity. What are the variances in the testing quality measures, and where do you think we're at in Minnesota? Thank you.
And Senator Jensen, we're going to try to keep questions really short. So Commissioner Kelly, we gave you a list and try to answer Senator Jensen's question. Then we'll get back to the list.
I would love to be able to answer that question, Senator Benson and Senator Jensen, but I am not the expert on testing. I can see if somebody can join the call to answer that question later. I don't know if Chris Erzman.
Yeah, is Chris on? Chris might be able to answer that one right now if she's here.
So, Dr. Erzman, to the reliability of our PCR test relative to objectively and then relative to the rest of the nation. And I know we caught you flat-footed. You probably weren't ready for your part yet, so.
You're on mute, Chris.
Actually, it looks like she's off mute, but perhaps headphones or something are plugged in. We can't hear you yet. All right, we're going to keep going, and Chris, as soon as you're available, pop back up. We'll do an audio test if you think you might need to restart. But so we'll come back to the PCR. The quality of the PCR tests I have as an open question. I heard that little has been done with serology, which we know will give us a much better idea of where the virus is in our community. There were contracts for testing, tracking, and tracing. I know there was a personnel contract that went out, and then there was a software contract. Those two pieces, could you talk to us about that while we're waiting for Chris to hop back on?
Sure. We actually, Madam Chair, have only received funding from the Coronavirus Relief Fund for the technology-related work on case investigation and contact tracing. We have not yet put forward a request for anything else related to case investigation, contact tracing yet. But we are hopefully going to be talking with you later this week or early next week about that, and need to advance a request next week for expanding our case investigation and contact tracing work. So based on what we've seen with testing and outbreaks and the populations that so far seem to be most affected by COVID in the last couple of months, and based on our testing strategy for the fall, we're working to design our case investigation and contact tracing strategy to best meet the needs of Minnesotans and policymakers. So our goal is to contact cases within 24 hours of receiving the lab report and to find effective ways to better serve our diverse populations and maintain the quality of data that can inform decision making. So to that end,
Commissioner, I thought we had talked about personnel and software back in May, and I thought there were funds released for that. So I thought we had a contract with a personnel sourcing company that could meet the requirements of various populations. Did we not do software? Am I misremembering that request?
So we did request about $8 million for a technology solution. And we have been talking about contracts for personnel side of the work, but we have not yet requested funding for that. We have narrowed the field down to 2 vendors, and their work is not going to necessarily be around personnel, but more assisting us with some of the technical aspects in terms of hiring staff and training staff and managing the surge of staff. We may actually have 2 contracts, one with a staffing agency that can get us a staff, and one with a consultant group that can help us to manage the onboarding and the surging and the offboarding and the training and the performance metrics of those staff.
Okay, and Commissioner, we talked about that in May, and we're using CARES money, which terminates December 30th, or is this other federal money?
Madam Chair, right, you're right. We did actually ask for a small amount, about $3 million of CARES funding for to help us in the interim and like the short term with surge staffing for case investigation and contact tracing. And we have contracted with Rose International for that. Mm-hmm. And so they are providing us staffing as we need it. And we, between that contract, our local public health partners, our partnership with the University of Minnesota School for Public Health, we had been getting some assistance from Blue Cross Blue Shield and Medica. Those arrangements are ending. But between all of that work, we have been able to manage to this point. And so we are going to rely on the Rose contract to get us through as we put a plan in place for the fall and the winter and the spring. And so we will come forward with a request for funding to get us out of the CARES funding through December. We're trying to strategize how we will continue that work in January without that federal funding.
Okay. So Senator Kiffmeyer directly to this point, and then we're going to hop back to Chris Ehrsman, and then I'm going to try to move more quickly through this. We've got a long list. So Senator Kiffmeyer, quickly to that point.
Quick question. Ms. Kelly, can you tell me how many of the 87 counties where you are using staff in the counties? It's been reported by me that our county staff is being used for this kind of work. Could you please give me the number of staff that are coming from counties and which counties?
Madam Chair and Senator Kiffmeyer, I will have to get back to you with the counties and the staff. Local public health is playing a pretty important role in this along with the state health department, and every local public health agency is a part of COVID response across the state. We are working towards a regional model with local public health where agencies that have the capacity to do this work will take on case investigation and contact tracing for their region, and we will contract with them to do that. That's our strategy that we're coming forward with. But right now, we do have counties have signed up where they have the capacity, have signed up to do the case investigation and contact tracing for their county. And I can get you a list of the counties that are doing that.
Thank you, Ms. Kelly. And if you could additionally just add to that, I know that there are beyond public health divisions. It's a little bit more than just a simple, if you have extra. They are taking time away from other important county public health work. So anyway, I'll look forward for that information. Thank you, Senator Benson.
Thank you, Senator Kiffmeyer. Chris, to Dr. Erzman for the Jensen question on PCR test reliability. I still can't hear you. My apologies, you're off mute. So I'm gonna have Ryan and Bailey make sure that we didn't do something to block you. We're gonna, if I was certain that you could do technical sign language, that's what I would ask you for. But for now, we're just gonna do our best. We're gonna keep rolling. Commissioner Kelly, there were some public outreach dollars. You were going to have a contract decision, the 2.25 million from the COVID fund, and has a decision been made for education outreach dollars?
Sure, there is, Madam Chair, a list of 17 diverse media vendors that we selected for the work through December. We've posted that on our website. I believe we've provided that list to the committee.
And that came through your inboxes today, so I'm going to ask you to review that. We're going to move on to, and Chris, it shows you're unmuted, so if you want to give us one more try.
I'm like,
Oh,
Yeah, got it.
oh,
I can hear you.
Yeah, it's terrible to be talking. And, yeah.
Yeah, reliability of the PCR test.
Yep. And so I'm going to say that I had reached out to our lab director, our lab CLIA director. And so when I asked about the sensitivity and specificity of the current molecular test, she said, it's a more complicated question than it seems. Our analytical sensitivity is 98%. We know that if a sample has at least 10 virus particles in it, we should be able to detect it. Things get a little bit more complicated when you talk about clinical sensitivity, which is real world performance. And so because at the public health lab, we don't get clinical information because we're not a clinical lab, we can't compare actual clinical symptoms with our testing. The literature is saying that the clinical sensitivity is around 50 to 70%. And so there are a lot of factors that can go into that. It depends on how much virus someone is shedding at the time of sample collection. And of course, that varies with where they are in the course of their infection and when things are being collected. And then obviously how the collection is done and transport time. So there's a lot of complexity to that, but the specificity is high and it's at 100%. So specificity is focusing on making sure that negatives are really negative. Sensitivity is looking at positive, but that gives you a little bit of an overview of that. It's complicated, but it's felt to be a strong test, and the tests that are being used by the university, Mayo, and our health department, we feel are good. And the reason that we have some concern about antibody tests, I'll just say this quickly, it's twofold. There are a number of tests that are on the market that may not have gone through FDA approval when they were really trying to make sure that tests were available rapidly. So that's one issue. So we want to make sure that tests that are being used are providing quality results. And then the other thing that we've talked about before is the fact that when we're looking at serology and antibody tests, you know, we don't know what is a protective level when you're looking at quantitative assessment, what's the protective level and what's the duration. And so those are some of the limitations that mean that we're cautious when we think about serologic testing. And I'll stop there so you can get to your other question.
Thanks. And Senator Jensen, do you need clarifying questions?
No, I appreciate it very much and thank you.
Thank you. So moving on, so I'm hearing that, because I thought there was going to be a clinically based serological test being done as part of the Mayo and U contract. So I was hopeful we were going to get some information about the virus that had perhaps already passed through our system, but it sounds like that is not at a deliverable place or an executable place. Is that correct? Either Dr. Erzman or Commissioner Kelly?
Madam Chair, excuse me for busting in here. It's
Commissioner
Commissioner Malcolm. I'm going to have to jump off in just a minute, but
Okay.
I don't know if Dr. Linfield's on the call, but I know there has been some serologic testing conducted under the contract. But what I have heard from Mayo and the U is that that the results were not yet at the quote unquote reportable stage.
Okay.
So we can get back to you on exactly what was done and what was found as soon as we get that from them. But there has been some, but not at a large scale.
I appreciate that. Thank you. And I just want to know that it's starting to roll because other states have been doing this for a while, and we had talked about it again in May and thought it was happening in July. So I'm glad that it's starting to roll out. So moving on to testing.
Madam Chair.
Yes.
Just before
Senator
the
Nelson.
commission, thank you, Madam Chair. I couldn't find my digital hand. I'm sorry. I couldn't get that raised. I just had one quick question for the commissioner before she might have to leave. And it had to do with the serologic testing. I thought I heard some of the discussion here earlier in our meeting today that the issue was that it was not reliable. But now I'm hearing that the real issue there's not, or maybe the issue of not reporting yet is because there's just not enough data. And in my mind, I'd like to know, if there seems to be a difference in my mind anyway, between not reliable and not having enough data. And I'm just wondering if the commissioner could just address that a little bit regarding what is the status of the serological testing as far as either enough data or reliability, or both.
Commissioner Malcolm?
And Madam Chair and Senator, thanks for that question. And it goes to sort of, I think the distinction that needs to be made between test reliable for what purpose. I think the question about test reliability really has had more to do with what does that tell us at an individual patient level about their past exposure or their level of protection going forward if they were found to have been exposed through a serological test. And that's where the unclarity or the uncertainty of the value of the test for that purpose is still hotly debated. But I think there's much broader agreement that serology testing can be useful for helping to estimate prevalence in a population. So I think that's an important distinction that your question gets at. It's not that there are no valid serology tests. It's more the question of what do the results really mean, and that they're not thought to be terribly actionable at an individual patient level at this point, but rather more useful for trying to identify what the prevalence of past exposure in the population might have been on a population sample basis. Although again, it doesn't unfortunately tell us as much as we might wish about what that means for future protection against reinfection.
Thank you. And then just a follow-up, though, I wouldn't want to get lost in the conversation, though. My understanding, though, is that the convalescent plasma therapy has shown great potential in reducing the severity of the disease. And of course, that would come after having serologic testing, knowing that plasma could be used for the convalescent plasma therapy. Is that correct? Is my understanding correct there?
Madam Chair and Senator, I think, generally speaking, that is right. And Chris might, if Dr. Linfield's not on the call, Chris Erzman might be able to contribute to this as well. But yeah, we're certainly aware that Mayo and others are doing some of that convalescent therapy research that I have heard the same as you, that some of those early results have been promising. But again, I'm not sure of the sample size that is available yet for kind of reporting results. But certainly happy to have Chris add if she knows more.
Dr.
Thank you.
Erzman?
Yep. Oh, yep. Thank you, Madam Chair. And just two sort of additional.
And Chris, we're having a little trouble. It feels like you might have a directional microphone.
Oh, is okay. Is this
Better. Thank
Okay.
you.
all right? So just a couple of comments related to the serologic testing. Certainly, if someone was PCR positive, what we found is that those individuals then do develop antibodies, so they would be eligible to participate in some of those activities when you're asking. So with the providing antibodies for treatment. The other thing is that when you are asking about reporting, at this point, we are not reporting on individuals who have had testing for antibodies because there's not a case definition at the national level. So we're waiting for the Council of State and Territorial Epidemiologists, a group I'm sure you think of often, to work with us to come up with the case definition. And so once that's available, then we will be able to report that data in a consistent manner across the country. But to let you know that to date, we've only had 93 reports that way through our laboratory reporting. And when we do report it, we'll make sure to separate it out. There's been a lot of concern about, are we inflating numbers or not inflating numbers or reducing numbers? And so we want to be very clear, which reports have to do with the molecular PCR test and which reports would be with an antibody test. And so when we have a case definition, we will make sure to keep those separate so you can track things that way.
Thank you.
Thank you,
Madam
Dr.
Chair.
Erzman. That was one of Senator Kiffmeyer's questions, the PCR versus the serology. So I'm glad you cleared that up
Oh, and
early on.
can I just say one additional
Dr.
thing, Madam Chair?
Erzman, sure.
And that is that you were talking about serologic studies, and one of the questions that had come up was about a study that we had requested approval for in May. And that study, we do have information on that. And that study, we've gotten institutional review board approval, and we're starting to move forward on how we can work on that. So, we can provide you with additional information there so you can move to other questions. But I just wanted to acknowledge that.
Thank you. I just want to know that the things we talked about are happening and are moving along, step by step here. So I have some questions about testing in general. We're starting to see spikes in youth cases, and we know that the number of people tested will increase. If we have a significant increase in the number of young people tested, we're more likely to see growth in cases. And I know at the end of May and into early June, we were testing long-term care facilities. And so have we shifted the populations that we're testing? How much does that contribute to a spike in youth cases? And as we move to going to school, and if we start testing in schools, the population we test gets younger, what does that do to cases? Can you help me understand if we're testing cross sections of the populations or if we're testing age groups?
Sure. So, Madam Chair, you're absolutely right that initially we had limited testing.
And again, we have directional microphone question. There you go. Thank you.
Eating my computer here. So, as you acknowledge, when we had limited testing capacity, we really focused on the most vulnerable. And so that was our elder population. And so we had many more cases in those age groups. Since testing has become more widely available, we have seen testing, increase in other age groups. And so when we look at testing roughly by age, and I can certainly send you the table here as well. But what we're seeing is that, for instance, our 20 to 29-year-olds, our 30 to 39-year-olds, and our 40 to 49-year-olds, these are groups that we're really seeing you know, a lot of testing in. So 20 to 29-year-olds make up 13% of the population. They represent 18% of the tests that have been done. Our 15 to 19 age group is about 6.4% of the population. They're about 5.2% of the tests. So what we're seeing is that our middle age, if you will, middle age, so 20 to say 50-year-old population, we're seeing a fair amount of testing in those groups, but particularly in the 20 to 29 and the 30 to 39-year-old age group, they are being tested at a higher rate than their proportion of the population. In other age groups, it's pretty consistent. And then when we get to the younger ages, so the 10 and under, we're seeing that the testing there is relatively lower than the percent of the population that they make up. So for instance, 5 to 9-year-olds make up just about 6.5% of the population, and they've been making up about 1.88% of the tests. So in the younger ages, they're not being tested proportionately to their proportion of the population. What's interesting is the positivity rate, and our highest positivity rate is in 15 to 19-year-olds at 8.2%. And then the next highest is in 10 to 14-year-olds at 6.2%, or excuse me, in 20 to 29-year-olds at 6.5%, and then at 10 to 14-year-olds at 6.2%. And I'd be happy to, I'll send you this whole table, Madam Chair, because it's just a lot of numbers. But the bottom line is that, you know, our testing is roughly proportionate. In other words, it's not like people who are elders make up, you know, 10% of the population and 80% of the testing is attributed there. It's not like that at all, but there are some subtle differences.
Okay. And I appreciate so much that you actually have that broken out by percent positive by age group, because it, as we see the aggregated data, it's hard for us to, we see an increase in cases among young people, but if we have massive increase in testing, it's the percent positive that would, I think, inform the conversation as well. So I would love to have that table. I'll send it out to the group. As we move to testing, as we move to a more restricted testing environment, do you think we'll see a decline in those age groups because they tend to be less symptomatic?
Madam Chair, I think that will probably be two things that will happen if testing becomes. That is that, you know, certainly our elder population is one that we need to test because we need to be able to intervene and make a difference in those living settings. But we have also prioritized childcare and in any sort of school setting as well. So if we start to see cases in those populations, those are also groups that we think would be very important to test. So we will continue to make sure that we can test in those populations as much as possible.
Okay, thank you. I'm going to try to keep moving. How long can a person test positive for COVID? We'll have to have you unmute. There you go.
Yes, I'm back. I'm at home this afternoon and I have a dog and I wasn't sure what she would want to contribute. And so that's why I keep making sure I put things on mute just in case.
One of the benefits of Zoom, we all get a little window into the ordinary life epidemiologist.
So Madam Chair, the data that we have available, and obviously it's continually evolving, is that people who have mild to moderate COVID-19 generally are infectious no longer than 10 days after their symptom onset. But people who have had more severe or critical illnesses or who are severely immunocompromised can remain infectious longer, sometimes up to 20 days, but usually no more than 20 days after symptom onset. But what's really challenging, so I just told you about infectiousness, but what's challenging is that people who have recovered can continue to shed detectable virus in their respiratory specimens for up to 3 months after illness onset, but at very, very low concentrations and in ranges where the feeling is that you can't detect replication competent virus. What that means is you can't get a virus that's going to be able to multiply itself and cause more disease. And we haven't seen infectiousness. There's no evidence that someone who's persistently, been able to shed or to have their the RNA picked up actually will transmit to others. So in general, we consider infectiousness to be about 10 days after symptom onset if you have mild to moderate disease, and up to 20 days if you've had more severe disease or if you're immunocompromised. But we do know that some individuals can continue to shed detectable virus, and so that can kind of throw things off with lab testing for them, particularly when there's been a test-based return to work or a test-based return to a facility. And so that's why we're really trying to focus on a time frame, because the data suggests that these individuals, although they may test positive for a while, are not infectious.
Senator
Thank you.
Benson,
And Senator Jensen,
follow-up question to that?
quickly, yes. Thank you.
Thank you. And thank you for that response, Ms. Ersman. In regards to that, wouldn't it be accurate to say that when we're finding the PCR test positive 20, 30, 40, 50 days later, that it may well be that because of the amplification of the test, that this may be nothing more than just a snippet of the RNA strand, and that the fact of the matter is we've not really been able to grow any virus in a culture past, I think, perhaps 20 to 30 days. Would you say that's accurate?
Dr. Ersman?
Dr. Ersman, I should have said doctor, I'm sorry.
That's no. Madam Chair and Senator Jensen.
Dr.
you're
Ersman,
absolute-
directional. There we go.
Sorry. Senator Benson, or Jensen, you're absolutely correct. And that, I guess that's what I was trying to get at, is that, people are shedding virus or infectious for about 10 days or 20 days if they're immunocompromised. But after that, you may be able to pick up virus, but it's inconsequential. So as you said, it's likely just a snippet. So no, you're absolutely right. And I'm sorry if I didn't say that clearly.
Thank you. So we're starting to talk about on some of the charts recovered. How do you define recovered? If somebody just quits talking to MDH and they don't end up in the hospital, are they recovered, or do they have to test negative? How do we define recovered?
Senator Benson, actually, we try not to use the term recovered. We talk on our website, we try to use the term no longer infectious, because we don't have the bandwidth to call everyone back. And we do know that some individuals, will recover and do well, 10 days after their onset of symptoms, they're fine. And we know that other people have prolonged symptoms. And so we're really trying to indicate when a person would be no longer considered infectious.
Thank you. And we're getting down to the very last, and we've got so many things that we wanted to talk about, but I want to leave some time for committee members. I have heard some people, nobody from MDH, talk about eliminating the virus. Do you think this is a virus that, smallpox we eliminated, polio is well managed? Is this a virus that we can eliminate?
Madam Chair, I surely wish we could, but I would say that a couple of things. One is that smallpox is the only disease that's been eradicated from the globe. Obviously, polio has been eradicated from the Western Hemisphere, and that's really positive. There are a number of factors that have to be in place to even consider a disease for eradication. And at this point, I would say that we're still learning about SARS or COVID-19 or SARS-CoV-2. And so I think it would be too early to to comment, but there are certain criteria that you need in order to even be considered for eradication. And I don't mean considered as if someone's going to vote. I mean certain characteristics that would make it possible. I think what our goal is really to make sure that we have a vaccine and therapeutics that are available so that we are able to control the virus in the population. And that's our initial goal.
And to the vaccine question, I keep hearing talk about a Pfizer vaccine, 2 doses available in December. What's your best information on vaccine availability?
Madam Chair, I'll say that the lesson that I learned during the 2009-10 pandemic was to under promise and over deliver. What was a real challenge there was that there was a lot of talk like, we'll have a vaccine by, October. Well, the vaccine was not available that early. I can tell you that we are starting already to start planning for how we would, look at vaccination. We're starting to plan for how we can enhance influenza vaccination for this season. So we're starting to do planning, but I think it's too early to predict a time frame for vaccine. I know one of the questions that you had asked, and I'll just mention this, is about prioritization. Typically, prioritization has been done through the Advisory Committee on Immunization Practices, which is convened by the CDC. Back in 2009-10, during the influenza pandemic, I was a voting member, so we helped develop a prioritization list. That would be the usual expectation, but the president has also asked the National Academies of Science to evaluate priority lists. So what will likely happen is there'll be priority lists that focus on our essential services and highest risk populations that will likely come from both of those groups. Then it's the states that work to identify those groups in their populations and help to figure out how we can make sure we get vaccine there. And ACIP is meeting, today.
Yeah.
They're meeting today to start talking about this. So, and then the other thing I was going to say, Senator Benson, is we did, pull data to answer some of these questions so we could be prepared. And so perhaps for the questions that we don't get to, we can, Lisa can work with you and send you some of that information.
That would be very much appreciated. And we've got a couple of hands up, and we're going to go for about 8 minutes speed round. Senator Matthews.
Thank you, Madam Chair. And I just want to piggyback off of that. I actually wanted to ask this to Commissioner Malcolm. Unfortunately, she couldn't stay the duration with us, but maybe Dr. Erzman or Commissioner Kelly can springboard off this discussion. I'm starting to hear from constituents that have noticed a phrase on your website on the COVID-19 page right now that's talking about future COVID-19 dials, what next phases look like. And some of the language is very curious that it states moving to the next phase of reopening will require a vaccine, an effective and widely available treatment, or the elimination of new cases over a sustained period of time. And I know there's been a lot of concerns among how broad executive orders and mandates have been that this administration has come out with. Sometimes running afoul of the Constitution and running afoul of statute. And I'm starting to get questions that I thought I want to just directly ask you with your phraseology here. Reopening will require a vaccine. Is there any talk by the administration of making a vaccine mandate as a condition of having a business license, operating a business, being out in public, any of these things so far? Can you expound on that, please?
Dr. Erzman?
Madam Chair, I absolutely, at first I wondered where you were going, Senator, but I understand exactly what your concern is. No, I think I can say that no, that requiring a vaccine, that's not something that we're even thinking about. But what that statement meant was that in order for us to get to a place where a certain proportion of the population is protected, and where we could feel comfortable recognizing that disease transmission will be more limited, we need to have a vaccine. It will require the availability and access to a vaccine that can provide protection to people. But I don't anticipate that we would be looking at requiring vaccination. As you know, we have a school law that allows for exemptions.
Madam Chair,
Thank you, Senator
real
Matthews.
quickly, thank you, and I appreciate that. I thought that's what your phrase was hoping to say, but I was getting questions about that, so I wanted to have that clarification. I also am for education and letting people make their own decisions if they want to choose that route, but I'm happy to hear that answer, and thank you, Madam Chair.
Thank you, Senator Matthews. Senator Nelson?
Thank you, Madam Chair. Yes, thank you, Madam Chair. I just wanted to, I think this is the group that could maybe appreciate this the most. Today the U.S. News and World Report listed the top hospitals in the nation, and Mayo Clinic, once again, our own Mayo Clinic, once again, was number one, I think for about the 5th year in the row. And I just think that's something for us to celebrate in Minnesota, particularly at this time. And I'm thinking about our discussion on testing. And I just wanted to really congratulate both Mayo and the U of M for their partnership and how they have really stepped up and worked together to increase the number of tests for the coronavirus. And just to kind of give the committee a little flavor of what that is, through July 27th, just 2 days ago, Mayo alone, it has performed 229,796 COVID tests. And so I think, and the daily amount can fluctuate between 2,500 or 10,000. So certainly we have met, and I would say surpassed that moonshot goal that the governor put out there. And I just want to publicly acknowledge that and thank them. And I know that's very important to this committee. I did have a question, and it had to do not so much with the testing, but with the modeling. And I think perhaps Dr. Erzman might be able, or someone else on the team.
And Senator Nelson, we don't have a model. And do you want to wait until the model comes out in August? Because we'll have a hearing on that.
Oh, no, my question is very simply, it has to do with what model has been used to dial back those dials. And that we've looked at the U of M model, and I just know that the most effective models are the ones that are done closest to real time. And I want to know how the effectiveness of the model that the governor, I believe, is using to determine how to dial back the stay at home or the closure mandates is being looked at. And certainly looking at a model that has a quicker turnaround, maybe a 1 to 2 day instead of a 48-hour turnaround. So I'm just curious on the model, Dr. Erzman, because we know it's a novel virus, but certainly the model has been wrong in a number of cases. Fortunately so, but I want to know how we could get to a more accurate model with more real-time data. More real-time data determining the model that determines how we move forward in our economy and with our schools.
Okay, Dr. Erzman or Commissioner Kelly, either. Dr. Erzman, we have some microphone issues again, if you want to answer the question.
Hey, can you hear me now?
Yes, thank you.
Oh, good thing my father was a dentist because you're getting a really close-up of my teeth. So I just want to clarify, Senator Nelson, that the dial back data that we're looking at is really not modeling. It's actually real data in real time. And so as the commissioner indicated, we don't use one single indicator, we use a constellation, but the indicators that we are looking at are very current. So we don't have to wait for the new model, for instance, from the university to get that information. And we actually track that every single day. So just to reassure you on that.
Thank you very much. And I don't know who could answer this for me, but we did have a question. Is there a distinction between died of COVID, or I'm sorry, died with COVID or died because of COVID? Because I know there's been some confusion. I just want to clear up what MDH is doing. If you have a heart attack and you test positive for COVID, that is classified as a heart attack, I would think, but I just want clarification. If somebody tests positive when they die are they listed as died because of COVID or died with COVID?
Madam Chair, so yeah, for when we talk about the number of deaths due to COVID, what we're talking about is someone who has tested positive for COVID within 30 days of death, and that COVID was listed on the death certificate as a cause of death. So in other words, we would not count someone who tested positive and later died if COVID was not listed as a cause of death, unless we did some sort of independent investigation and determined that there was something unusual. But that has not happened yet. So in other words, if you tested positive for COVID and then had a myocardial infarction or died in a motor vehicle accident, those deaths would not be counted as deaths from COVID. So it really is, something that is linked to the death and to the death certificate.
Senator Benson?
I see Senator Jensen unmiked. He, I think, probably is the only person on this call right now who's actually written a death certificate. So I'm gonna give you a little extra grace.
Thank you very much. And actually, because I'm so old, I've actually done far more death certificates than I might have liked. But Dr. Ersman, I just want to say thank you to the Department of Health. I think that you have as a department tried to stay nimble, and you've made adjustments. And what I hear you saying is that you are going to look at that powerfully important sequence of causation just as you would want us to look at any other death. And that if COVID-19 in that sequence of causation appeared to be the underlying cause of death, then that's the kinds of deaths you're counting. But if it happens to be a contributing condition or happen to be identified, that's not necessarily automatically going in. And I think that there are many states that are not doing it that way. So am I correct in regards to the sequence of causation being honored?
Dr. Ersman?
Madam Chair and Senator Jensen, yes, we have a lot of teams, and we actually have a death team, which probably not the preferred team to be on, but they are evaluating and reviewing all of the deaths and things. So yes, we're not just counting if someone dies. And as I said, if there was something else like a motor vehicle accident, myocardial infarction, even if you had COVID, that would not be listed as a COVID death unless it was considered contributing.
And I want to thank you. Part of the reason I ask these questions is because there's so much social media and cable news chatter about counting positive serological tests with cases and counting unrelated deaths because you had COVID. And so I just want to call those out so that we know what data we can trust and that you're open to questions being asked. And so I appreciate that. And I did tell MDH an hour. We're a little bit over that time. I guess I have more questions. I'm going to try to get a call with the commissioner at some point. I know you have a lot of data. I will share that with the committee. I feel like we're moving, the goalposts have moved on COVID, where we're trying to get to zero hospitalizations or very low case numbers. And so are we going to get to herd immunity, or are we waiting for a vaccine to try to get to herd immunity? Because this virus doesn't feel like it's going to be eradicated.
Madam Chair, yeah, I mean, I think our goal would be that we manage cases. We cannot stop COVID at this point. So our expectation is not that we won't have cases, but that the cases that we do have are able to be managed, and that our healthcare system has the capacity to deal with them. And so that's why, for instance, today on the media call, I was emphasizing that we're starting to see our numbers of hospitalizations and ICU bed use kind of go up, because we just want to make sure that when we do have cases, that if individuals need that care, they can get the care that they need. But I do think it's important to say that none of us has the expectation that we won't have any cases, not at all. We know that that's not possible. And in terms of herd immunity, we know that as people develop illness, that they have some level of protection, but we don't know how long it takes. And so that's the challenge. We have 6 months of experience with the virus, and so that makes it harder to predict. And it looks like I posted, I was able to post some of the data on the chat, but
Yeah.
I will send it to you in a better format.
See that. I appreciate your transparency with data. And members, I don't see any hands, but also out of respect, MDH has been head down working on this since the end of February. It might have even been January for Dr. Erzman. So I just want to be thankful for the hour that you gave us. We'll try to do this probably again in August when the model comes out, and try to stay on top of what's going on, do our best to dispel social media myths or things that are happening in other states versus what's happening in Minnesota. Briefly, Senator Kiffmeyer, and then we're going to let MDH go and move over to our care providers. Senator Kiffmeyer.
Thank you. Yeah, thank you, Madam Chair. And I saw the chat box, Ms. Erzman, as far as those numbers. It was very interesting to see the older people tended to test at a lower percent of positivity versus the younger. And yet our highest proportion of deaths are coming from the older. Very interesting. I would have expected to have seen the opposite, a higher positivity with the older, considering how many deaths we have. But whether it's now or maybe in a follow-up email to just comment in regards to that. And so I think it also makes us realize that when you get a higher number of positivity overall, it doesn't necessarily equate into the seriousness or the increase of deaths just because of that, especially if the younger folks are being tested more frequently now, and they may have higher positivity, but maybe lower serious illness.
So thank you, Senator Kiffmeyer. Dr. Erzman, do you want to address that? You
Yeah.
looked like you had your hand raised. Go ahead and unmute.
Madam Chair, can you hear me? Yes.
Absolutely, yes.
Okay. So Senator Kiffmeyer, just one note. Part of the reason that we may see a bit of a lower positivity in our elder population is, even though it's a very severe disease for them, is because we have been, you're probably familiar with our efforts in long-term care to make sure that we are tracking and identifying every case. And so we are doing what are called point prevalence surveys. So we're testing, we may test a whole long-term care facility and all their staff. And so that means that we're hoping that most of those residents are not positive, but that means that we're testing a lot in that population. So that may help for it. But yes, thank you.
Right.
Thank you. Exactly what I needed to help interpret that information. I needed Dr. Erzman. Thank you.
Absolutely. Thank you. Members will disseminate anything MDH sends us. I know they did significant work in preparing for the hour that we had with them. So I want to let Lisa and everybody at MDH know we are grateful. We're going to let you go. And Mary Krinke, welcome, Ms. Krinke.
Thank you. Thank you, Madam Chair and members of the committee. For the record, my name is Mary Krinke, and I'm the Vice President of Government Relations for the Minnesota Hospital Association, and we represent hospitals and healthcare systems across Minnesota. Thank you for this opportunity today. I remember testifying on April the 2nd, and it was at the first meeting of the state Senate's your COVID response working group, action group on COVID. And at that hearing that day, I'm sure there was a great deal of apprehension in my voice as I was thinking about everything that was coming our way, and hospitals were working and thinking about preparing for the surge of COVID patients and very sick patients. And we were thinking about what we were going to need in terms of retrofitting our hospitals, our ICU beds, purchasing supplies, and training of our healthcare workforce. Quite frankly, we felt a little overwhelmed at that time of what we thought would be coming our way. I just want to let you all know that since then, and really we felt that flattening that initial curve really did help us buy time to get us in a much better place than we would have been without flattening that curve. We were able to have time to get the healthcare system ready, and we needed that. I'd say right now the hospital systems, our hospitals, our doctors and nurses, and our care teams have done an outstanding job of caring for very sick COVID patients. And I think Minnesota has done a really superior job working with the Department of Health and you all and healthcare providers across the state. I'd like to spend my time today just talking about kind of what we call the 3 S's: spaces, supplies, and staffing. So first, I'd like to start out with the hospitals and retrofitting and getting to our ICU bed capacity that we have now. So the availability of additional ICU bed capacity really is very dependent on how we can keep our workforce and that critical ICU care team healthy. That is number one, to keep that ICU care team healthy, and that will help us maintain our staffing in our ICU beds. Currently, there are 1,224 ICU beds in Minnesota that are staffed. And that's a really important distinction. These beds are staffed. And right now, as of yesterday, 85% of those ICU beds were full. But I think it is important to point out to the committee that as of that last update yesterday, 17% of that capacity was for COVID patients. So we have started back caring for other very ill patients who need care in an ICU bed, but it is not all for COVID. So 17% of that ICU capacity right now is for COVID patients. Within 72 hours, hospitals will have the ability to bring online an additional 943 beds. That is extremely important to know as we see an uptick potentially in COVID cases, that we do have some ability to surge with our ICU beds. Once again, the ability to staff those beds is different than just having the physical bed in a room that is retrofit. The challenge will be to staff those beds. While the number of COVID-19 cases is growing, the average age of those individuals testing positive is greatly lower than it was 3 months ago. And from what we know so far, and I realize this changes, the severity of the cases for younger individuals is usually not as great as it is for our older population. This reduces the pressure on our ICU bed capacity and our usage. This could obviously change very quickly as things potentially spread to our vulnerable populations. But right now, we do not believe there is a shortage of ICU beds in our statewide. We believe we can handle a potential surge, but that would depend on how bad the surge was and the ability to care for those if we can get the necessary staffing. I do think it is important to point out that in the Twin Cities, a couple of our trauma hospitals usually have seasonal uptick of trauma cases in the summertime, and a couple of our big trauma hospitals in the metropolitan area have been at very high capacity and have had to divert patients. So that doesn't mean that the system as a whole is overwhelmed, but a couple of those trauma hospitals have had very high capacity. I'd like to talk now about supplies and break this down to ventilators, personal protective equipment, and testing. So first on ventilators, and I think this is one of the better news I have to share today. Minnesota currently has 980 ventilators in the state, with 419 of them in use, about 43%. Shortages of ventilators has not been the problem that we thought it might have been. This is due to a number of reasons. Number one, drugs like remdesivir are making a big difference. And so as our state gets shipments from the national stockpile and getting the remdesivir into our hospitals, that has greatly helped in our treatment and caring for COVID patients. Number two, our healthcare providers have learned so much about the treatment of COVID patients. We're now putting patients in a prone position instead of on their back. And we have seen that this has greatly opened up lung capacity. And I'm sure Dr. Jensen could provide more information on this, but in the prone position, it has effectively expanded lung capacity, and we have been able to prevent mechanical ventilation for many of COVID patients. The next item I'd like to talk about is personal protective equipment. And the supply of personal protective equipment for now, it is better than it was a couple months ago. However, the global supply chain will continue to be a problem as our whole country and other states are experiencing surges. We are competing against other states for personal protective equipment. And as states see surges, it obviously hurts our capacity to bring in PPE. This has been a challenge. I think it's better than it was in March. Hospitals and our healthcare providers are continuing to follow guidance from both the CDC as well as the Department of Health. The policy is to conserve PPE. We feel that this is very necessary because we don't know exactly what will happen. So our members are still in a position of conserving PPE. We feel that that is necessary. There is an acknowledgement that this can change very quickly. We don't know what the burn rates will be, and so we feel this conservation policy is the most important. The federal stockpiles have not come to Minnesota, and they have been allocated for the COVID hotspots around the country. This means that hospitals have had to rely on their own purchasing supply chains, which can be more expensive than they were pre-COVID and also not as reliable. So we kind of get things in a wave and then we are unable to find things. So the PPE supply is not always consistent, but for now the situation is better than it used to be. The Minnesota Department of Health is trying to get to a 60-day supply. This is very important, particularly for our long-term care settings, and you'll probably hear more about that from them. But if we're hoping the state can get to this 60-day supply on hand, and I'd ask you to defer any questions regarding the status of that to the Department of Health. The next issue is a little not quite as rosy, and that is the issue of testing. And I know you all have heard a lot about this already today. And quite frankly, the testing it continues to be a challenge for our hospitals. I am hearing more and more from particularly some of our rural members that the lag time is now 5 to 6 days for getting back test results. They're fearful that it could be as much as 8 days. It is not the shortage of the sampling supplies, it is the processing supplies. It is the reagents that they need in the laboratories to process the tests. I have been on a call recently with our HR, our human resource directors, and they have shared with me a concern and a question that has come up repeatedly. What do they do about an asymptomatic healthcare worker who has been exposed to COVID from a family member, and they are waiting for a test result now that could take days and days, and in the meantime, they're having to quarantine that healthcare worker, and this is potentially a real problem for our providers, and that is the ability to get testing results back quickly for our employees. So I know this is somewhat controversial getting into the prioritization of who should be tested, but I really need to stress with you all, prioritization needs to be for our patients first and for the nursing home residents, but then the next group of people really needs to be our healthcare workers. We need to keep our doctors, our nurses, our nursing home employees. They need to have prioritization of testing, because if we don't keep them safe and keep them healthy, we're going to lose this battle, okay? So I would like to challenge the department sometimes on some of these general community testing events. And I know that they're popular, and I know you hear from your constituents who like them, but I just want to urge people, as long as we have this shortage of reagents, we need to prioritize testing for our healthcare workforce. So that is just something I feel is something that we need to kind of get on the record, that testing of healthcare workforce is really a priority and a concern for hospitals right now. And finally, the last issue I want to mention is our staffing concerns. The first priority has to be to keep our healthcare heroes healthy. And this is dependent on training, adequate supplies of PPE, and yes, that testing issue that I mentioned. There have been two executive orders from the governor that have been extremely helpful to our hospitals that I would like to mention to you today. They are Executive Order number 23 and Executive Order number 46. Executive Order 23 allows for the delay of fingerprinting submissions for those healthcare practitioners who are already licensed here in Minnesota. So this would mean a doctor or a nurse who's already licensed here in Minnesota. When their annual renewal is up, they wouldn't have to go get another fingerprint submission in. Many of these fingerprinting locations are closed right now, so this delay has been very helpful to keep our workforce in place. And then the second one, Executive Order number 46, has allowed us to bring in healthcare workers from other states. And several of our hospitals have brought in highly trained ICU nurses and respiratory therapists to work directly in our COVID-19 care units. So what we're asking is if there could possibly be legislation that would set a time-limited period, 60 days, 90 days, after the executive order emergency powers end, that we could keep these healthcare workers here without an immediate shutoff of the clock. So our members, if they're still caring for COVID patients, would need some ability to ramp that down. So that's just a request that we would have regarding our staffing. So our ability to keep these ICU beds that we have that could be used is dependent on keeping our staff healthy and the staffing of that. Madam Chair, I just have one other thing that I would like to throw in today that has come up repeatedly from our members. We are very concerned that Minnesotans have postponed or foregone much needed care for things like heart conditions, diabetes, cancer. We're seeing stories about the potential rise in breast cancer because people have delayed treatment. And we really need to get messaging out to the public, both our healthcare providers and you all as legislators, to your constituents. Please encourage your constituents who need healthcare services. Don't delay those services. What we don't want to see is an increase in cancer cases, diabetes, and even mental health cases. We know there are people suffering right now because of COVID and staying at home and mental health issues. So we just want to urge people to please get the care that they need during this time. There are ways to remain safe, and that gets to the whole precautions that we know. Wear masks, social distance, stay home if you're sick, and yes, wait for your test results. If you think you might have COVID, don't go out, wait for your test results. So please, we urge people to follow the public health instructions, but we also want to encourage people to get the care that they need. So, Madam Chair, thank you all for all your support during this time. In closing, it's been a marathon. I just wish I knew which mile marker we were on.
Right. I really hope we're not at the bottom of the hill. But anyway, I do have one question before we switch over to the long-term care folks. Something we talked about in the spring was the fiscal consequences of the delayed care, the non-emergent care that was delayed. How is the fiscal stability of our hospital and clinic systems? We're hearing that there are some clinics that are evaluating their operations. So you don't have to give us a perfect answer, but some indication would be.
Yes. Thank you, Madam Chair. I thought about going down the route of finances today, and then I thought, nope, let's just focus this on the care. During the time when we were delaying all elective and non-emergency procedures, and I'm so happy that Senator Benson did not use the term elective, because elective to me implies that, oh, you're getting a facelift done. These were procedures that were delayed, and many of them are vital healthcare services that people needed. During that time, hospitals were losing $31 million a day. And so our hospitals have taken a big financial loss during that time. It's getting better. I don't want to say that we're back to where we were pre-COVID, because we're not, but the financial picture is better than it was when we were closed and basically shuttering all other healthcare services. So we're hoping that people will get the services that they need. They'll go back to their clinics when they're sick. the financial situation is tough. It's not good. We're not where we were pre-COVID. So
Thank you. Senator
I
Coran, I know you-
I can provide a more thorough outline for
Great.
people soon. So
that would be helpful. Senator Coran to this point, and then we'll move on to long-term care.
Thank you, Madam Chair, and thank you for bringing up that point. We know there's going to be a fundamental shift in how we deliver care. You know, the telemedicine and all of those things are going to occur. Rural Minnesota is certainly, you know, I'm hearing it from multiple clinics that are going to be shut down, or that the word is on the street that they're going to be shut down. So in order to do this successful or transform this, we know it well, but what's the community engagement? Or I don't expect you to have it, but the community better be fully engaged instead of having the healthcare system come down and say, well, that, you know, it's been nice knowing you. We're moving on, and you guys can drive 30 miles now to the closest clinic. So it's going to be really important. We know it's going to change. And what does it look like?
yeah,
Ms.
Senator,
Greinke?
if I may, telemedicine is actually maybe one of the heroes and saviors for our rural clinics and hospitals, as they're able to keep services local by being able to tap in an expert in the cities. That way people don't have to drive into the cities for all their follow-up care. So by using telemedicine to a greater extent in rural Minnesota, it might actually help us preserve services there. I think a better way to think of it maybe is that we may not be able to provide all services, the full array of services in some of our rural communities, but I hate to think, just like you said, I hate to think of them shuttering down. There's too many essential services that are needed in a close proximity.
And I think what
Thank
I
you.
heard Senator Coran say is communicate in advance. I know we worked with Mayo Clinic on some of the decisions they were making. Community engagement before news breaks would be really helpful. And with that, I'm going to move on to long-term care. I saw Mr. Pearson, so thank you, Ms. Greinke. Mr. Pearson and Ms. Thurlow, thank you. We didn't mean to put you at the end. You guys have been kind of at the heart of all the COVID talk. So welcome to the committee. Give us an update of where you're at and what we need to help going forward.
Sure, Madam Chair. I think I'll start out and then I'll turn it over to Ms. Thurlow. My name's Toby Pearson, Care Providers of Minnesota, today testifying on behalf of the Long-Term Care Imperative. First, our members would like to just say thanks for inviting us to testify. This committee does a lot of very important work. We're proud of the work that our senior care providers have been providing, and yet at the same time, we know there are tremendous challenges that still exist. Back in May, there was a 5-point plan to protect Minnesota's long-term care residents and workers. And coming up with that plan, I think the state decided that long-term care, as we have seen in all the data, the outbreaks can be very severe. The risks are very special and unique to long-term care, and that we needed to have a coordinated plan in order to protect residents and workers during this pandemic. We'd like to say that progress has been made in some areas of the plan, yet challenges still remain. We're not yet prepared to say, hey, we won, victory. We have to continue to be vigilant and responsive to the changing nature of the virus. Some of the success areas that we have seen so far, many of the providers that had early outbreaks are now actually COVID-free. Some of those have done a lot of work as far as getting back with their employees and with their residents and have a lot of strong success stories. Some funding has been made available to help providers with the COVID-19 costs. I say some because it's not quite enough, but I'll let Ms. Thurlow get into that a little bit more. Some providers have had better access to testing, particularly those who have had access to the National Guard and the additional lab contracts. But we still struggle a lot with testing, and I'll go a little bit further in a minute. While we, as Ms. Greinke mentioned, PPE, yes, it still is a problem here in long-term care as well. And I think one of the successes is that there has been a greater focus on guidance with infection control. So many of our members who may have struggled with some of the infection control when we first started out with COVID, when we did not know the difference between whether or not it was transmitted through the air or on surfaces. As we've learned more about the transmission, the infection control procedures have gotten a lot better in many of our facilities. However, the successes are not fully implemented across the board. You have different providers doing things differently. Because of the location, a lot of times, it's different in greater Minnesota than it is in urban centers. We're concerned that the public across the state is going to hear that we're doing really well in all these areas. They're going to look at the numbers and say, why can't we open up more? Why can't we have more visits? And I'm sure you're hearing this. Why can't we have more visits to our long-term care facilities? Well, we know that as positive cases grow, particularly in our younger folks, the community spread will continue, and that will pose an increased risk for long-term care. We have been continuing to urge caution in determining whether or not to require senior care settings to reopen to visitors. We did implement essential caregivers, but that again, we're still concerned about what will that mean to folks that are residents in our facilities. Because as we learned early on, the virus spreads very quickly and can have devastating results in our facilities very quickly. So the first critical issue that I'll raise, and then I'll turn it over to Ms. Thurlow, is testing. I can kind of echo a lot of what Ms. Krinke just said. Testing, although it's probably even more complicated for long-term care settings because there's approximately 1,600 assisted living and nursing facilities. So trying to get testing for all of those residents and workers is a huge undertaking.
Yeah.
We are not in a place where there is full access to testing for symptomatic and asymptomatic staff or residents that is consistent with the CDC guidelines. We believe the cornerstone for this work is the state of Minnesota has to take central leadership role, directing the testing activities, to be the primary payer of testing for employees and uninsured residents so that we can get payment. We don't want our employees having to pay extra copays every time they have to be tested. And it can be a series of tests if you test positive, or if your facility has outbreaks, the frequency of those tests is going to increase. So the number of copays an employee could potentially have to have can increase. The mixed messages, as Mary Krinke pointed out, the mixed messages about availability, the changing timelines of when you get your results, all of these can come into play when you're trying to figure out how can we clean up our setting, how do we keep this out, what do we have to do, how do we move people, how do we cohort them to address all of this. I think we're all aware of the need to have accurate, timely test results to prevent unwitting transmission, but we have yet to see a plan, and it gets a little frustrating because I know it's very complicated for the department, but we have yet to see a plan that fully addresses testing without barriers of cost, gaps in supplies, and delays in results. So with that, I will turn it over to Ms. Thurlow to continue our testimony.
Ms. Thurlow.
Thank you, Madam Chair. And for the record, my name is Carrie Thurlow. I'm the Senior Vice President of Advocacy for Leading Age Minnesota, and here on behalf of the Long-Term Care Imperative. So I've been tasked with providing the committee a brief update on 3 issues related to long-term care, on PPE availability, on staffing, and then a quick look at payment issues or financial stability. So I'll just start with PPE. And I would say that I would generally agree with Ms. Krinke that the situation has gotten better, but with all things in long-term care, it's more complicated than that. PPE continues to be a critical need in long-term care settings, especially for assisted living. Part of that is because of the complex nature of supply chains and the reliance on allocations based on previous use. And part of it has to do with the fact that assisted living, for the most part, has not had the same benefit of federal stockpiles or necessarily even the same access to some of the supplements that hospitals and nursing homes have had. And keeping in mind that we quite frankly serve more seniors in assisted living here in Minnesota, which is unique to every other state in the union, and have more of them, it continues to be a particular problem. Supply chains have warned providers in long-term care in our memberships to expect delays, potentially up to 2 to 3 weeks, and to also expect shortages, that their full orders will not be fulfilled. As Ms. Krinke indicated, part of this is because we have a national supply chain. We are definitely impacted by the Sun Belt and the demand that is occurring in other parts of the state. And so that is impacting our abilities. We are expected to exhaust our private supply chains before using state and federal stockpiles, and that has proven to be challenging. And while most providers would say that they have okay supplies, that they're doing okay right now, that dramatically changes as soon as there is an outbreak and the burn rate increases dramatically. So things can turn very quickly. The other thing that I would point out about PPE is that costs of PPE have increased dramatically, up to sometimes threefold. And that is having a tremendous impact on both assisted living as well as nursing home settings. There is, in particular, we are hearing significant concerns about the costs related to surgical masks, gowns, and gloves, and that we expect that trend to continue for some time. Looking ahead, we remain concerned, as Mr. Pearson indicated, we continue to urge caution for modifying visitation guidelines, because as the expectation to also provide PPE for essential caregivers or visitors, in addition to our staff, the demand on PPE in our settings continues to grow. So that is another reason why we continue to urge caution. As to staffing issues, I would first say that our members continue to work very hard to address staffing concerns, and that we have appreciated the partnership with the state to continue to address staffing concerns in long-term care settings. So for example, we know that there has been work to provide funding so that providers can use COVID-19 bridge funding to help with appreciation pay and such, to help attract and fill the gaps in our workforce. Our providers would say that that's been met with some mixed results. Some have had very good success, and all are very appreciative of the efforts. I want to say that, and Senator Benson, I would acknowledge your committee's work in helping secure some of those grants that have helped with that. But still, there is a great deal of fear of coming into work in our settings, understandably. The federal supplements for unemployment also make it difficult to recruit and retain displaced workers to our settings. So we still struggle with staffing. We have also appreciated, for example, the state's efforts to supplement our staffing with emergency staffing needs through the National Guard, and that has helped as a temporary solution. But again, as we look to the broad expanse of providers throughout the state, it's not a full-term solution. At the same time, in certain areas of the state, we hear that even temporary access to temporary shrinking staffing pools is shrinking. So for example, in the southeast part of the state, one of the major temporary staffing agencies has now, in order to sort of meet the demands of all of their clients, has stopped providing temporary staffing to assisted living settings altogether. And so we have an acute need for temporary staffing, particularly in that southeast corner, and we are worried that that trend will continue statewide. The last but not least, I've been asked to comment on payment issues, and this is complicated to do given that we can talk about nursing homes, assisted living, and adult day, and each have their own unique challenges. So maybe the key takeaway I would leave you with is that assisted living in general, well, we would say that our most stressed area of the continuum of long-term care is adult day. Let me start there by saying that because they have had to completely close since March in response to the pandemic and are now only able to open up to 50% capacity, and in some cases that's not even financially viable, that is a sector that is extremely stressed. And we appreciate the Senate's discussion about supports like retention grants. That holds promise, but know that that sector continues to be very stressed and that many providers have outright closed and likely will not come back. Kind of next in the continuum, assisted living tends to be more financially stressed than nursing homes at this time. That's partially because we've provided more financial supports for nursing homes than we have for assisted living. So nursing homes, for example, have been by and large greater beneficiaries of CARES Act money from the federal government. We've made available 12A10 money to help supplement staffing. We look forward to hearing very shortly an announcement of using state funding to help with testing funding as well for nursing homes. That corresponding funding support has not necessarily been as readily available for assisted living. The exception to that is the MDH grants that this committee and the legislature made early on in the pandemic have been accessed by a great number of assisted living providers to help with one-time preparation costs. So that has been appreciated. And there has been some elderly waiver money made available for assisted living providers with outbreaks, but that money will expire on Friday. And as far as we understand, that money is not coming back. And so given sort of the contrast there in terms of financial supports, assisted living providers are relatively more financially stressed than nursing homes. And then nursing homes continue to be stressed partially because of occupancy issues and continued increased costs, as we've discussed, because of PPE and staffing. So I think both Mr. Pearson and I are very happy to answer any questions that you might have, and thank you for the opportunity to testify today.
And members, we are past time, but I want to give you a few minutes to ask questions of Ms. Krinky and Mr. Pearson, Ms. Thurlow. Senator Marty, you have been very quiet. I am glad to see you. Go ahead with your question.
Thank you. Two questions are unrelated to the testimony there, but the first one is the essential caregiver guidelines that Department of Health put out. They were guidelines, and if I'm providing care to a loved one, one or more members per family can get that. That's voluntary. I'm just curious what you know of the response being. Is that something that everybody's going along with? They've been waiting for this. Finally, they have a way to have these folks in, or is it something they're pushing back against, or what's happening?
Ms. Thurlow?
Madam Chair, Senator Marty, thank you for the question. I believe that guidance just took effect on July 25th. That with the providers had a little bit of lead time there to make preparations, and that's understandable. I would say that the essential caregiver provisions and guidance that MDH has put out, I want to first say that we're supportive of it. And it is meant to be an exception to the visitation restrictions, and is meant to accompany also the outdoor visitations that are allowed now as an exception to restrictions. Provider responses as to how they will be rolling out essential caregivers, I think it's fair to say that these are early days, and there are mixed responses to this. It does require additional staffing. There are specific criteria that must be met. Not everybody gets to be an essential caregiver. It does require additional staffing to screen and bring in those extra visitors at a time when we already have stretched staff. And I think that many providers are proceeding with caution because their first priority is the safety of their residents to avoid the spread of COVID-19. And balancing that safety also with the concerns of social isolation is something that each individual location is struggling with. So I know at least our organization, I think care providers as well, I think we are polling and continuing this conversation with providers. I can't tell you how many are rolling it out this week, but I do know that providers are working very closely with families to communicate and to try to make it work within their settings and balancing both of those concerns. I don't know.
The only thing I'd add to that is that I think some of our providers that are in more hotspot type locations are being way more restrictive and very much more concerned about the safety. And then those that are in places that have fewer COVID positive folks are probably doing a little bit more to move forward quickly because, as Ms. Thurlow said, we're always trying to balance that social isolation, the need for people with the balance of if the virus gets in there, it spreads really quickly. So I think that's another factor that you'll see in the implementation of the essential caregiver.
Madam Chair.
Senator Marty.
I understand it and understand it's very early on in the process. I am hoping that they tend to be receptive because yes, they have more work to do in terms of screening the folks coming in, making sure they're safe. On the other hand, I mean, I've heard from several constituents. I'm the one who who gives her the meds. I'm the one who does the bathing. I'm the one who does this and all sorts of things that they've been helpful with in time. And so in some ways it saves efforts. I'm not denying at all that it's going to take more time to get them in there and so on. But I'll be curious, and I think we'll all be watching to see how it happens, because I'm hoping that facilities recognize this is a big win for the patients, as long as it can be done without spreading COVID. But one constituent said, hey, she's been providing these services to her mom for many years, and she said that her biggest risk isn't getting COVID from her daughter, who is who has been isolating everything else. Her biggest risk is missing medications and other things. But anyhow, enough on that. I have one other question, and that
Senator
is,
Marty.
Madam Chair, thank you. There was an article in the Strib in beginning of July, I believe, that said there was the Ombudsman for Long-Term Care was saying there was like a 30% increase in complaints about people being dumped or services cut off or evicted, whatever, where they were being pushed out of facilities. And the article mentioned some horrific illustrations of cases where they got no help and where they were sending them to. And I just wonder if the industry, if you have any responses to that, if you see that changing, if you see what's being done about it.
Mr. Pearson.
I think there's probably 2 or 3 different things to bring up in response to that. The first is, as a membership organization, we never encourage our members to do that, so it's not coming from us. However, best practices we can put out there, blah, 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 you know that story. I think the challenge that folks were having was, how do you deal with non-compliance in a constructive way? And that oftentimes there's more to a story that gets printed in the newspaper than maybe on its face. We never encourage our members to do that. We always try to get them to do best they can with their residents. We hope that that type of behavior decreases, but without getting into the specifics, other than sometimes the story prints more of one side than the other, I guess. It's hard to balance. Again, if that resident is not wearing a mask, not abiding by the rules as far as isolating, going out, you're always balancing how does that affect the rest of the individuals in that facility. So it's a tough balance, but we would hope that our members would not just be kicking folks out for no reason.
And if I may,
Ms. Thurlow or Senator Marty? Yes.
No, go ahead. Go ahead.
Ms. Thurlow?
And Senator Marty, and thank you, Senator Benson. Senator Marty, thank you for the question. The only thing I would add is, as Senator Marty knows, that we are having ongoing conversations with a number of stakeholders. Many of our members report that they've actually, especially during the time of COVID, are actually working very hard to avoid service terminations and lease terminations in assisted living housing with services, because of the recognition that this is an extremely difficult time. So these are extremely fact-specific instances. We look forward to continued conversations with stakeholders on these issues going forward.
Senator Marty?
Madam Chair, just real briefly, thank you. I recognize every case is different and so on. It's just, I think they said there were 150 some cases in a 3-month period, and that's a lot of cases, and I hope we can keep the pressure on for people not to be doing this, because it's about the worst outcome for people. So thank you, Madam Chair.
Thank you, Senator Marty. Senator Matthews, I think you have our last question.
Thank you, Madam Chair, and I'll be brief. I have a question that someone from a long-term care facility, a worker, reached out to me with wanting a clarifying question, and I thought maybe our long-term care folks could help with this answer. So in my district, there were a couple people that were getting moved, I believe down to Hopkins to a COVID facility that I think a couple residents had a positive test. I believe that was something we had talked about months ago as probably a smart idea of making an isolated area that we could try to care for these people. But this worker reached out and said they were informed that after a positive test, a resident was not allowed to be tested again for 90 days after that, and didn't know why that was. And I hadn't heard that either. And I wanted to bounce that off of you. There was some concern from families. Was there an accurate test right away? If there was an asymptomatic situation, like the family was basically told there's no other recourse. So I wanted to ask you if you knew anything about that, or if you had any information I could pass along about that.
Ms. Thurlow?
Senator Matthews, thank you for the question. I'm not aware of the reasons why that would occur, but we'd be happy to work with you offline to get more information. And I think both associations have clinical experts. I don't know if it's a clinical issue or a payment issue, or just quite frankly, a testing bottleneck. But we'd be happy to try to give you more information offline if you'd like.
Super, thank you.
Okay. Thank you. Well, I want to thank Ms. Thurlow, Mr. Pearson, and Ms. Cranky. I am increasingly concerned about staffing and testing, and now I'm also hearing PPE. So I've got some follow-up to do with each of you. But I know Ms. Thurlow and I have a future conversation scheduled, so I'll be checking in. I just want to make sure that I believe that as Minnesotans move back indoors, we're going to see an increase in cases, and that will put stress on the system. And I just want to make sure that to the extent we can influence preparedness, that we help you be prepared. And heaven help us, right now it looks like influenza is fairly mild in the Southern Hemisphere. It would be nice if we mirrored that in the Northern Hemisphere this year, but I am not counting on anything. In 2020 has COVID and protests and evidently murder hornets. And so if we could have a mild influenza season, I think that would be just excellent. I want to thank the team who helped put this together, the list of questions. MDH, I see Lisa's still on. I know your team did a lot of work gathering data. We'll get that out to everyone. Thanks to the committee members who paid attention. I hope that by following up on commitments that were made, we keep a better handle on what could be coming at us this fall. COVID's going to influence a lot of decisions from now and well into the future. And I want to make sure that we have engaged with the departments who are responsible for regulating. And with that, I'm seeing no hands. I want to thank everybody again. I wish you well, stay healthy, and we are adjourned.
Thank you.
Thank you.
Bye, everybody.